Dr. Langis Michaud from University of Montreal School of Optometry. Very happy to be here in Phoenix for the optometrists meeting. We will talk about myopia, challenging cases in myopia. And the first part of the lecture is to explain at this moment what we think are the mechanisms leading to myopia. And it's more complex than we think. And there's not a conflicting, but a different contribution of factors like defocus and contrast and spherical aberrations and chromatic aberrations. So we have to understand at the end that the retina really dictates the eye growth, and it is a response, a direct response to the quality of the image that is provided through the optical device we put in front of these eyes. So we can really manage myopia by managing the quality of images that we provide to the eye. Second part is obviously to cover challenging cases. Then it's not, -2 patients coming with, regular single vision glasses, not so evolving and easy to fit in defocus contact lenses or contrast glasses. These are the ones with syndromic myopia, -6 at the age of 3, or a high level of astigmatism, or those still evolving despite the fact that we have put in place the best strategy possible. So it's to think outside of the box and consider patient per patient cases, because myopia management is all about that. It's all about customization and to analyze carefully the cases in front of us. And most importantly, the most important takeaway is if you want to evaluate the progression of myopia as a standard of care, use axial length as the matrix. Refraction is very good to diagnose myopia. Axial length is the matrix to control evolution. I compare to glaucoma. You do not manage glaucoma just based on pressure. You will look at visual field and you will scan the optic nerve. Same thing for the myopia. You have to manage myopia measuring axial length and then decide on the intensity of your treatment and if the evolution is normal or not normal. One of the cases is about compliance. I think that with all the tools that we have in hand, orthokeratology, soft multifocal lenses and glasses, anti-myopia glasses, they are all equivalent at the end. But compliance plays a significant role. If the kid is not wearing the device as we prescribe them, the evolution will be just like if they are not treated at all. And this is part of the case history we have to do on every visit. In fact, just a question about how kids are using the device, how they are applying the drops we prescribe. I have this example of a young lady, a very young patient, but I prescribed atropine and she still evolved a lot over several months. And at a given moment, I asked her mother, is she using atropine? And she said yes. But in the exam room, the pupil wasn't dilated. So I said, there's something wrong here. And I just asked the kid to show me how she applied the drops. And she closed her eyes before putting the drops in because obviously itching was present. And I just had, the cue why, the progression was there because she put the drops, but not in the eye, but it was on the lid. So we have to check those things and so non-compliance is certainly an easy one to fix and to identify. Go step by step. One of my mentor in the past, said to me, you can eat an elephant, but slice by slice. So challenging cases, if you try everything at the same time, you will not know what is working, what is not working. So go step by step, and then you will realize how to adjust to the evolution of that case. The second thing is that a kid evolving a lot in the last 2 years, for example, cannot be stabilized in a matter of 6 months. So take time to make sure that you evaluate over the long term instead of the short term, the efficacy of your treatment, and then readjust accordingly. There's a lot of questions that we don't know the answer about the mechanism. For example, we know a lot, but we don't know a lot as well. So why this device in that particular case is not working, while in many other cases it's the best that we can prescribe. We look at the retina, we look at everything, and nothing really so obvious. And again, so we have to dig a little bit more sometimes in order to explore other avenues. Environment is certainly playing a role. You know, we are here in Phoenix, it's 40 degrees Celsius outside. You know, certainly practitioners cannot, you know, recommend to be outside 2 hours a day for kids. They will burn. As simple as that. So we have to find other ways to make our recommendation in order to have good life hygiene and to alleviate the problems in the future. But yeah, those cases, again, you know, listen to patients and try your best step by step in order to manage them, and it will work. For myopia management, if you didn't start your practice and include that in your practice tomorrow morning. And second thing, don't wait to implement strategies to control myopia. I see a lot of practitioners, okay, it's just a minor myopia, -1, we will wait a few months just to see how it goes. It will evolve. The child is growing, and you may lose the opportunity to make a difference in the future. If you wait too long to intervene, your efficacy will drop severely. So as soon as you diagnose myopia, it's time to manage it properly with appropriate device and appropriate strategies. So single vision glasses are sugar for diabetic patients or a pack of cigarettes for asthmatic patients. So please don't prescribe them anymore. Prescribe the solutions that are working to control myopia and keep these things outside of pathology in the future.